Ladies and gentlemen, we are now moving on to the most awaited highlight of the day, the 27th Annual Scientific Congress 2025 organized by Sri Lanka College of Pediatricians, a moment of deep significance and enduring legacy. It is with great honor that we gather for the Dr. B.J.C. Perera Research Prize Oration, an occasion that pays tribute to a pioneer, a visionary, and a towering figure in Sri Lankan pediatrics. Ladies and gentlemen, may I kindly request that you rise as the ceremonial procession is entering the hall.
To read out the citations and to award the medal to our orator for this year, I invite on stage the President of the Sri Lanka College of Pediatricians, Dr. Duminda Samarasinghe.
Good morning, ladies and gentlemen. It's with great pleasure that I introduce Dr. Meranthi Fernando, a young, energetic pediatrician whose contributions have left an indelible mark on Sri Lanka's pediatric healthcare landscape. Dr. Fernando is a senior lecturer in the Department of Pediatrics at the Faculty of Medicine, University of Kelaniya, and serves as an honorary consultant pediatrician at the Colombo North Teaching Hospital, Ragama. She serves as one of the team members of the multidisciplinary team of Colombo North Center for Liver Disease. Her journey in medicine began with her graduation from the University of Kelaniya in 2009, where she was awarded the prestigious gold medal in pediatrics. From the outset, pediatrics was her passion. She was ranked first in the entry examination for the MD Pediatrics program, which she completed in 2016, and further expanded her expertise by obtaining MRC-PCH in 2019. Having witnessed the devastating impact of liver disease among children, Dr. Fernando committed herself to making a change. Under the mentorship of Professor Shaman Rajendrajit, she initiated specialized training in pediatric hepatology. She was accepted into the world-renowned liver unit at Birmingham's Children's Hospital, UK, for her overseas training, a pivotal milestone in her career. There she not only gained invaluable experience, but also discovered her true professional calling. At a time when many peers chose to remain abroad, Dr. Fernando returned to Sri Lanka with a mission to redefine the future for children battling with liver disease. Her vision and determination laid the foundation for Sri Lanka's first pediatric liver transplantation program. Today, she is the driving force behind this initiative with a multidisciplinary team in a remarkable collaboration across transplant, surgery, anesthesia, intensive care, radiology, and other specialties. What once seems impossible is now a reality, thanks to her commitment, innovation, and relentless effort. Beyond her clinical excellence, Dr. Fernando is also a dedicated academic. Since joining the University of Kelaniya in 2013, she has published over 40 index publications, owns 468 citations to date, contributed to 3 book chapters, and earned multiple awards, including Merit Awards for Scientific Publication from the National Research Council 2012 and 2014, and Senate Honors in 2024. Her leadership has been recognized on international stage. She was selected as Young Physician Leader by Inter-Academy Partnership through island-wide applications and attended the World Health Summit in 2023. Dr. Fernando's journey of excellence began long before her medical career. As a student of Newstead Girls College, Negombo, she excelled not only in academics but also in dancing, comparing, and debate, early indicators of a dynamic, well-rounded personality. On a personal front, she shares her life with her husband Dilum, and together they are proud parents of their beloved son Jason. Ladies and gentlemen, it is both an honor and a privilege to welcome Dr. Meranthi Preetika Fernando, MBBS, DCH, MD, FRCP, CH, to deliver the distinguished Dr. BJC Perera Research Prize, Oration 2025. May I now cordially invite Dr. BJC Perera to the stage to award the medal.
Good morning. Thank you, sir, for that kind introduction. President and the Council of Sri Lanka College of Pediatricians, fellows and members of SLCP. Dr. BJC Perera and family, distinguished invitees, ladies and gentlemen. It's my great pleasure and privilege to deliver Dr. BJC Perera Research Prize Oration 2025. A tribute to a legendary pediatrician who has magnificently uplifted the childcare in Sri Lanka. Dr. BJC Perera was born on the 14th day of July, 1947. He obtained his MBBS from the Faculty of Medicine, University of Colombo. He completed his postgraduate studies from PGIM, University of Colombo, and RCPCH, UK. Since then, he undertook a remarkable and impactful journey in pediatrics as a brilliant clinician and an innovative researcher. Dr. BJC Perera held many positions up to date, which included being the founder president of SLCP and being a past president of SLMA. Dr. Perera owns a number of articles and book chapters to his name, where his pet area in research was childhood respiratory diseases. This laid the groundwork and many achievements for children with asthma. He was the first clinician to introduce the nebulization as a treatment modality to Sri Lankan children through scientific evidence. He was the founder president of Respiratory Disease Study Circle and pioneered the development of the subspecialty of pediatric pulmonology. He currently serves as the joint editor to Sri Lanka Journal of Child Health and serves as the sectional editor to Ceylon Medical Journal. He is well known for his glamorous speech with a unique accent, where he is named as the spokesman of SLCP. Though I did not have the opportunity to get trained under him in person, I had the privilege of associating with him through SLCP. Apart from his academic achievements, the sincerest aspect which would inspire me about this legendary pediatrician is his humble gesture and the willingness to help. With that tribute, Mr. President, ladies and gentlemen, let me share our experiences over the last 5 years on transformation of pediatric liver care in Sri Lanka through an era of transplantation. Clinical medicine evolves and progresses on innovation and research. Dr. Thomas Tarsal innovated something which was realized to be an impossible dream. It was none other than liver transplant in 1963 in a child with biliary atresia. Liver is the largest solid organ in the body which can fail irreversibly due to many reasons. Once liver failure becomes medically refractory, it is cured by none other than liver transplant. The spectrum of childhood liver diseases span from a self-limiting hepatitis to a life-threatening liver failure due to many reasons. The leading disease requiring liver transplant in children is biliary atresia. In children, indications for liver transplant includes 4 main disease presentations, irrespective of the primary etiology. These include end-stage liver disease, cirrhosis, medically refractory acute liver failure, unresectable liver tumors without distant spread, and metabolic liver diseases affecting quality of life. Liver transplantation is a miraculous modality of treatment for a child with liver failure, which will transform death to life within a few hours. Part of the liver is often obtained from a blood group matched living donor or a deceased donor, which will be transplanted to the sick child. Following transplant, the child is expected to be on lifelong immunosuppression, which is the slightest cost, which has to be paid for that second chance at life. Liver transplant recipients are expected to sustain a normal quality of life otherwise. Since the times of Stasel in 1963, liver transplantation developed across the world to become the standard of care for both children and adults at present. However, in Sri Lanka, this service was developing only for adults, and there was no liver transplant program for children up until 2020. As pediatricians and pediatric trainees, we all have gone through the suffering of children along with their families due to liver failure without having access to liver transplantation. Only a handful of children were able to travel overseas for a significant cost, which was often raised through public funds. In this prestigious oration named for Dr. B.J.C. Perera, who had been a real innovator to clinical medicine through science, I would like to discuss these 3 aspects of innovating specialized pediatric liver care to Sri Lanka, along with the challenges faced while making it into a liver transplant program. Further, I would proudly share the milestones achieved over the last 5 years by a multidisciplinary team. Establishment of a specialized pediatric hepatology service. Ragama, initially North Colombo Hepatobiliary Unit, later became Colombo North Center for Liver Diseases. It's well known for its expertise for liver diseases and transplantation for many years. I, as an undergraduate and postgraduate, had the opportunity to be nurtured in Ragama, getting exposed to children and adults with liver disease, which made me to develop a subject interest in that area. Subsequently, my training under Professor Charman Rajendrajit and the overseas training in the liver unit of Birmingham Children's Hospital gave me the wisdom and the confidence to open a new horizon for children with liver diseases. In 2017, where we had limited data on the burden of pediatric liver diseases, we evaluated all the pediatric hepatobiliary referrals to University Pediatric Unit at Ragama and presented at the annual Congress of SLCP in 2018. We realized that the majority were due to biliary atresia. There was a significant number of deaths due to liver failure, which is just the tip of the iceberg. Further, we analyzed 28 children who had liver transplant from overseas between 2010 to 2018 and realized that the survival was promising with good quality of life. Since the establishment of pediatric hepatology service at Ragama in 2020, it has catered a total of 663 new referrals till April 2025 from all the provinces of the country, unveiling the national disease burden. The disease pattern predominated with biliary atresia, Wilson disease, and acute liver failure. In subsequent slides, I would like to emphasize how we published on these three most prevalent diseases in order to enhance the awareness among pediatricians. Biliary atresia is a disease of unknown origin which caused progressive liver disease and only be cured by liver transplantation. However, early diagnosis and Kasai surgery would greatly improve the outcomes by delaying the need for liver transplant. We published an algorithm to facilitate early diagnosis of biliary atresia while highlighting the place for primary liver transplant for late presentations, as Kasai would be disadvantageous for these children. Wilson's disease is an inherited copper toxicosis, which would mainly affect the liver and brain. Most of the patients with Wilson disease exhibit their first presentation in childhood or adolescence. We were able to shed more light into the field of Wilson disease by reiterating the early diagnosis using a diagnostic score. And further, we described the different presentations of Wilson disease to facilitate timely diagnosis and treatment. In 2023, we analyzed our cohort of pediatric patients with Wilson disease and presented at SLCP Annual Congress. There were 22 patients, and it was found that the majority had hepatic manifestations, and 27% of them required liver transplant. By 2025, the Wilson's cohort had grown to 44. We came up with the interesting data which was presented at the International Liver Transplant Society conference this year in Singapore. Median age at the diagnosis was 10 years, and there were 10 children who had acute liver failure, 90% of them requiring liver transplant. In the modern era of pediatric hepatology, whole exome sequencing is essential to unveil most of the genetic diseases in view of etiology and to predict the genotype-phenotype correlation. With much respect to these two personalities, we were able to develop a trusted link to perform genetic studies which directly influenced the patient care. We analyzed 54 patients with liver diseases who underwent whole exome sequencing, and 22 were confirmed with Wilson disease. And we were able to describe the most prevalent genetic mutation in this cohort from Sri Lanka. This work was presented and awarded at the annual conference of National Genetic Symposium in India this year. Acute liver failure has always been a scary emergency to the pediatrician, especially when it is medically refractory and you are only left with the transplant option. We presented on our experience over the last 5 years on acute liver failure in ILTS Singapore. Our data incorporated a cohort of older children, where the median age at referral being 8 years. This is mainly due to the fact that we did not accept young children for transplant in the initial phase of the program. The majority were from low income category who would really benefit from free health care. The median time from listing to liver transplant surgery was 72 hours, which is truly remarkable. The causes of acute liver failure were Wilson disease and autoimmune liver disease, where 31% of cases the cause was indeterminate, which is compatible with world data. Having identified the disease burden and the pressure resulted through a growing number of referrals and the mortalities we witnessed, we were compelled to embark on the dream of liver transplantation for children in this country Mr. President, ladies and gentlemen, on the 14th day of July 2020, a new gate was opened up for pediatric healthcare in Sri Lanka by the achievement of first successful pediatric liver transplant for a 9-year-old girl from Jaffna who was diagnosed with progressive familial intrahepatic cholestasis type 3. She was lucky to have a second chance at life from her own mother. 5 years later, she has now grown into a beautiful adolescent. This milestone resulted in a significant fame and national appreciation. However, we realized that completing one transplant is not the same as establishing a transplant program. In the next few slides, I will highlight the challenges we faced over the last 5 years in establishing a liver transplant program and how we navigated through those challenges based on these two publications. The work, which was published in the Journal of Pediatric Transplantation, received Senate honors from the University of California last year. Soon after the first pediatric transplant, Sri Lanka was subjected to the dual strain of COVID-19 and economic crisis. It was difficult to navigate a transplant program amidst these crisis situations. However, we were able to turn the negative to positive by attracting more donations during that time, with which the program progressed. Liver transplantation is essentially a multidisciplinary task, which involves many specialties. In most of the liver transplant centers, it is the only dedicated job for them. However, in the local setting, we find specialists who perform this task mostly amidst all the other duty commitments. Further, with the brain drain in the recent years, it was challenging to retain trained staff. The current program is blessed with these outstanding personalities across the specialities, led by Professor Rohan Siriwardana. Development of the para-specialties and the support from hospital administration was crucial on the progression of the program and for its sustainability. Every team member would count, whether it's medical, nursing, or other, to achieve successful outcomes following liver transplant. Training all the staff to do this highly specialized task was challenging, however, exhibited good progress. Infrastructure, logistics, and consumables. Transplant outcomes are directly influenced by the state-of-the-art infrastructure and isolation facilities in the view of infection control. We found progressing with higher numbers is truly challenging with the existing infrastructure in a teaching hospital which caters many specialities. We were fortunate to meet this great philanthropist, Sir M.H. Omar, who were unbelievably generous to build and equip a dedicated liver transplant center with state-of-the-art infrastructure in Ragama. This illustrates the rapid growth of the number of pediatric liver transplants with the establishment of M.H. Omar Liver Care Facility, where we were able to perform 15 pediatric liver transplants during the last 12 months, which is a great achievement. Fourthly, liver transplant essentially requires a liver graft from a living or a deceased person. Shortage of the grafts and lack of timely availability of donors in an emergency situation is a challenge everywhere in the world. We evaluated our donor cohort and found a median age of 33 years, while males predominated. The unique observation was a significant proportion of living donors being altruistic Buddhist priests, which accounted for 30% of the donors. in addition to parents donating for their children. Living donor transplant outcomes were far better than deceased donor outcomes. The main reason for disqualification from donation was fatty liver disease. These are real-life examples of parents donating to their children and happily discharging home. And these are some of the examples that children who were at near death received the gift of life through altruistic donation. Poor economic background of patients and families. While we published the experience of the liver transplant program in the initial 3 years, we realized that all were from poor socioeconomic backgrounds. Though it is a free health care, these families have to go through many costs due to prolonged hospital stay and due to unavailability of the medications and consumables in the government sector. This is a 12-year-old girl who was fortunate to receive a liver transplant and return to school with the assistance of many charities who supported the family. Lastly, awareness and attitude towards liver transplant among patients and clinicians. We assessed 186 caregivers of children attending to the pediatric liver clinic at Ragama and found their knowledge, beliefs, and attitudes were quite promising. However, there were some gaps to be filled. Further, we were able to develop trust from the clinicians all over the country representing a national referral pattern. And all transplanted children were handed over back to the community and local pediatricians who excellently looked after these children following liver transplant. Moving to the final aspect of this oration, I would like to present the sequential milestones achieved over the last 5 years in the history of pediatric liver transplantation. The first successful pediatric liver transplant happened in 2020 for this lucky girl from Jaffna. With the addition of pediatric liver transplant program to CNCLD, we were able to complete 50 liver transplants in 2020. This 9-year-old girl was referred due to acute liver failure and was escalated for liver transplant from her own mother within 2 days. It was a dream come true for children who were dying with acute liver failure in this country. Along with that, the transplant outcomes of acute liver failure following liver transplant exhibited 83% of survival rate, with more positive outcomes from living donors. Liver transplant is best to be ABO compatible. However, with the advancement of the modern medicine, it's possible to perform ABO incompatible liver transplants, especially in young children. This milestone in 2022 opened up a new gate for Sri Lankan children. Infants with biliary atresia are the main group of candidates in pediatric liver transplant programs. Embarking on this degree of complexity, especially with portal vein hypoplasia, was truly a groundbreaking achievement. In late 2024, we were able to help a 5-month-old baby with acute liver failure through an altruistic donor within 36 hours of referral. Since both parents had fatty liver disease, a Buddhist priest who had completed the donor workup volunteered. Though the child was having hepatic encephalopathy with seizures prior to transplant, she recovered with complete neurological recovery. Hepatoblastoma is the commonest liver cancer in childhood. In certain instances, liver transplant is the only option. The most recent success of the program is transplanting a child with multifocal hepatoblastoma who has shown a complete recovery along with adjuvant chemotherapy. Amidst the liver transplant options, we explore non-transplant options as avoiding transplant is best if it is possible at any setup. We described a 4-year-old girl who was otherwise would have required liver transplant due to medically refractory pruritus caused by Alagille syndrome. With a series of MDT discussions, we explored the possibility of internal biliary diversion for her, which resulted in a complete recovery of her symptoms. This was possible only with the development of hepatobiliary services for children along with the transplant team. This table illustrates the gradual approach of the team on complex scenarios and how we developed in the learning curve over the time. You could appreciate in 2020 at the beginning, the number of transplants were less and we embarked on older children with higher weight, and we could not incorporate any cases of biliary atresia. By 2025, the number has grown and we were able to embark on liver transplant surgeries in younger children, infants with lower weight, and we have gone beyond the anatomical difficulties like portal vein hyperplasia, and we have included donors with prior kidney donation. This was possible with all these collaborations helping us at difficult circumstances. We were aware of the learning curve and our limitations. We sought help at the best interest of the patients. Mr. President, ladies and gentlemen, in this prestigious oration, I would like to conclude that the pediatric liver care was transformed over the last 5 years through a dedicated multidisciplinary team, along with their efforts in transplantation. The flight has just taken the ground clearance at a difficult setup. Now the future is to fly safely in a stable manner by keeping the team together while meeting expectation of all the parties involved. This work belongs to a wider team and many public-private partnerships, hence my sincere gratitude is expressed to SLCP for giving us this prestigious occasion to present our work, and Dr. B.J.C. Perera and his family for gracing this occasion. My school, Newstead Girls College, and universities, my teachers and trainers who nurtured me. These 3 personalities who really shaped my clinical and academic career, I'm really grateful. The Liver Unit, Birmingham Children's Hospital, UK, who gave me wisdom and the confidence to work in pediatric hepatology and liver transplant. My work in family, Colombo North Center for Liver Diseases, all the staff. We went through so many hardships, difficulties, and achievements together as a family. Department of Pediatrics, with a sincere heart, Faculty of Medicine, University of Caledonia, Faculty, University, and CNTH Ragama, Ministry of Health, Lady Ridgeway Hospital for Children for their important collaboration in many aspects. Donors and charity, you are sincerely appreciated. My friends who were there with me in all times. Last but most sincerely, my family. My parents who raised me, Dilum, who shared the journey with me with so many difficulties and hardships, and Jason, my purpose of living today. Thank you all for your patient listening.
Ladies and gentlemen, that concludes the Dr. B.J.C. Perera Research Prize Oration, a truly fitting tribute to a pioneer in Sri Lankan pediatrics. We thank once again for the inspiring words and honoring his excellence with such a grace. Ladies and gentlemen, as the ceremonial procession departs, please once again rise to show your respect.